radiograph for the skull. We have computed tomography, which is a CT scan, whether it is with or without contrast. And we can also do MRI, magnetic resonance imaging for pediatric age group. And please take note that this radiograph and also computed tomography, these two modalities, they utilize radiation, X-rays that has an ionizing radiation hazard. So we will talk a little bit about it later. So first I want to introduce the ultrasound cranium. Because during infancy, the cranium is not, the skull bones are not fully fused, and we have anterior and posterior fontanelle. The anterior fontanelle will be fully closed by 1 year, 6 months old. But as the patient is more than 6 months old, the anterior fontanelle is getting more and more, it's getting smaller and smaller, and make the ultrasound cranium more and more difficult to perform. So the ultrasound cranium is usually just for the baby, which are less than 6 months old. Right, so next time when you all become a houseman and want to request an ultrasound cranium, make sure it is for a very young baby, less than 6 months old, and make sure that you get the appointment date when the patient is less than 6 months old. Okay, probably you go to request today, but the appointment given was when the patient is going to be 1 year old, that's not the point. All right, so just make sure that the whatever ultrasound cranium is done for the baby less than 6 months old, because during that time the anterior fontanelle is still wide enough for us to put our ultrasound probe and then allow the ultrasound acoustic wave to penetrate the patient's anterior fontanelle. So the advantage is really because there is no radiation and you can do it anytime that you all wanted, and it's readily available. So we even the patient is not cooperative also, we can still perform the ultrasound. This ultrasound, it depends whether it wants to be done in the radiology department, or they can be even being done as a bedside examination. So if the patient is not very stable, and so we can actually do the ultrasound bedside. But the disadvantage is, of course, the ultrasound is quite operator dependent. And not only operator dependent, it's also machine dependent. So the person who do the ultrasound have to understand what they are seeing and what are the pathology that they are looking at. Okay, and also be able to pick up the abnormality that is in the ultrasound so that to make the correct diagnosis. And also sometimes we are very limited by the anterior fontanelle. Although we say that the general rules, less than 6 months old, the anterior fontanelle is adequate, but sometimes in some of the patients, they do have a smaller anterior fontanelle. So when the anterior fontanelle is smaller, the field of view that is allowed for us to visualize using ultrasound is actually small. So that is also depending on whether the fontanelle is big enough or not. All right, so the usual indication is actually for routine preterm screening. For this preterm, if they have a hypoxic ischemic injury, the mainstay of their assessment is by ultrasound cranium, not by MRI, not by CT scan, right? And then the next indication that is usually being done for is to look for hydrocephalus. Right, because sometimes when the patient has a congenital hydrocephalus or have hydrocephalus of any by any cause, the head circumference is big, and usually the anterior fontanelle is actually quite wide, and sometimes the wide anterior fontanelle can even last after 6 months old. So this one is not the fixed rules. All right, it depends on patients and also depends on the indication. The next one is to look for subdural effusion or collection. Sometimes when the patient presented with fever, meningitis, but you feel like the anterior fontanelle is a bit too tense or too bulgy, too bulging out, then you wanted to see whether there's any subdural collection or effusion that is collecting within the subdural spaces, and we can use ultrasound to visualize it. Sometimes the patient just presented with seizure and we do not know what really happened, and when we do ultrasound we saw this subdural effusion, collection, or even subdural hemorrhage. So it is the ultrasound cranium is the mainstay, is the screening for screening purposes. So it's less optimum to really demonstrate very well the rest of the intracranial abnormality. Some of the abnormality, if it's gross enough, we can use the ultrasound to see, to visualize it. But if the abnormality is not very obvious or not very big, the ultrasound might miss it. All right, so you all have to bear in mind that ultrasound cranium is mainly for screening and to look for specific pathology such as the one listed here. So these are the image of the ultrasound cranium. We can do it in the coronal plane, or we can do it in the sagittal plane. And you can look at this small picture here. This is how the probe is being oriented. So this is a sagittal plane ultrasound cranium, and these are the coronal views of the ultrasound cranium. And if the anterior frontal allows, we will be able to see quite a lot of the brain. All right, but you can see the sideway here, there are a lot of shadowing. There's not much of signal, not much of information. It is because of the skull. All right, so the smaller the anterior frontal, the larger the area that you might not be able to see. So this is at the level of, this is the lateral ventricles. You can see, we can visualize the lateral ventricle, and these are the left cerebrum and the right cerebral hemisphere, and this is the temporal lobe. And we do have this tentorium cerebelli here, and below it is the posterior cranial fossa structure, which are the cerebellum as well as the vermis. And this is at the posterior coronal view, and you can see the occipital horn of this bilateral lateral ventricle. These hyper echogenic structures are the choroid plexus within the bilateral lateral ventricles. In sagittal view, we are checking for those midline structure, whether the patient has corpus callosum. All right, and then we look at the brainstem, which is the hypoechoic structure over here. And also, this is the vermis. We also check for any posterior cranial fossa abnormality. So these are basically the view of the ultrasound cranium. And if there is hydrocephalus, you can understand that the lateral ventricles, they will be dilated. Okay, fluid is anechoic in the ultrasound. So this region, they are the fluid. All right. After we use the curvilinear, sometimes we will use the linear probe to check for the subdural effusion up there. So these are the example of cases that we do ultrasound cranium for. This is a 3-day-old pram baby born very early, which is 26 weeks of gestational age. And you can see that compared to the normal ultrasound cranium that I just shown, this patient has dilated lateral ventricle. This lateral ventricle is dilated. All right, and you can see that there are increased echogenicity around the lateral ventricle region. So these are periventricular echo density. This periventricular echo density, they indicate periventricular leukomalacia. All right, it's one of the findings in the hypoxic ischemic changes in the preterm baby. And also, if you are careful enough, you can't see any sulci in this brain. It's because the sulci is all effaced. The patient also has some cerebral edema. So now 14 days later, what happened to this periventricular echo density? You can see some of it has become dark. All right, it has become quite dark, similar to the echo density of the CSF fluid within the ventricle, and these are becoming a cyst. So these are periventricular leukomalacia with cystic formation. And inside there, you can see there is a lot of echogenicity material within the bilateral lateral ventricle. This patient actually also concurrently having intraventricular hemorrhage. At 8 weeks old, you can see most of the periventricular echo density has resolved, and we are left with more cysts of different sizes. And the patient still having hydrocephalus. But now we can see more of the cerebral sulci, so the brain is less tight, not that edematous anymore. So next one, we move on to computed tomography. the most important thing to remember for computer tomography is utilize ionizing radiation. And because of pediatric age group, they are rather sensitive to all this ionizing radiation. And that's why we try to limit the use of computer tomography. The advantage is, of course, it is fast examination. It is much more faster than MRI. And majority of the hospital will have at least a computed tomography, a CT scanner, but not all hospital has MRI machine. The disadvantage is because of the ionizing radiation, and also the tissue contrast is actually poorer compared to the MRI. The indication is mainly in terms of the trauma or in terms of looking for intracranial hemorrhage. Okay, these are the emergency setting. So we need a fast imaging modality. And also if the patient is not very stable to stay very long time in MRI machine, then the CT scan is a option. Sometimes the CT scan demonstrate more bones, better skull anatomy compared to the MRI. So that's why some of the cranial synostosis patients, when they need to go for operation, a CT scan is a must for a pre-operative planning. In other cases, we can do high resolution CT temporal. This is the HRCT temporal we call at the temporal bone for those patients who need a cochlear implant for pre-operative assessment. We are looking at the inner ear structures or the optic capsule. And also the CT scan can also look for other intracranial pathology, but this usage should be limited to you have to consider the MRI first. Unless the MRI is very hard, it's not accessible, you don't have an MRI list, you don't have the machine, then only you will consider to do a computer tomography to look for intracranial pathology other than these three indications. Otherwise, the MRI is usually preferred. Okay? So how much radiation dose is this CT scan being delivered? You can see that in adult, the CT scan head in adult is just equivalent to 100 chest radiograph. But in the newborn, the younger they are, the radiation is much higher. Okay, this for newborn, the CT brain is equivalent to 200 chest X-ray, and then at 1 year old about 180. And only at the 5 years or 10 years old and above, the equivalent dose is rather similar to the adult. But this haven't considered the patient, the sensitive for the body tissue in the pediatric compared to the adult. Why is that so? It's because the pediatric age group patient has more red marrow. So the red marrow in the bone, they are rapidly dividing, and hence they are radiation sensitive. They are sensitive to radiation. So if they are being destroyed by the radiation, they are more easily being destroyed or being altered by the ionizing radiation compared to the yellow marrow. So in adult, our marrow is mainly fat because we don't really need so much of hematopoiesis. But in children, majority of the red marrow are still remaining in the skull. All right, so it is for pediatric age group patients, they are much more sensitive to radiation. So if you can try to avoid asking for CT scan for pediatric age group patients, unless truly indicated. So because of that, because the continuous effort of trying to reduce the number of ionizing radiation CT scans in the patient in the pediatric age group, a lot of places came up with different guidelines of who and when we should order a CT scan for a pediatric age group patient in the setting of trauma. Okay, so this is the what we call the short form is PCAN, all right, Pediatric Head Trauma CT Decision Guide. And you can see that this guide for 2 years old says that unless you have any of these, then the CT scan should be proceed. If the patient has normal GCS, has no palpable skull fracture, has no altered mental status, then you should assess the patient further, whether the hematoma is frontal, whether the patient having loss of consciousness of more than 5 seconds, or whether the patient is acting abnormally per parents, or the mechanism of injury is actually quite severe. And these are the criteria for severe mechanism of the injury, more than 3 feet high, or the MVA have an ejection of a passenger or whatsoever. Okay, if all these risk factors are not there, then the CT scan is not indicated. All right, so meaning that you see, even the frontal skull hematoma per se, is the CT scan is not indicated, and the patient should be observed. And if there is no further deterioration of the patient, the CT scan, you can discharge the patient. The CT scan is not indicated. All right, unless you have any of these, then it's either you continue to observe the patient or to perform a CT scan. This is by the clinical judgment. So this is for patient younger than 2 years old. So in patient more than 2 years old, they suggest that any of these, we go to CT scan, yes. This is similar, okay? And also these signs of basilar skull fracture, such as CSF rhinorrhea, or you can see ENT bleeding coming out from the external auditory canal, right? All these are the signs of basal skull fracture, and yes, the patient will need a CT scan. And if no, then you look for other symptoms such as vomiting, loss of conscious, severe headache, severe mechanical injury, and maybe perhaps after a joint decision, the CT might be indicated. All right, if all these findings are not there, the CT is not indicated. Not everyone fall from the chair or fall from the sofa need a CT scan. All right, remember that. And of course, other places have other types of guideline. These are just one of the example. So what the CT scan will look like? The CT scan, we can actually reformatted it into all the 3 planes, which is the axial, coronal, and sagittal plane. Right, so this is in the coronal plane. All right, you can see that the ventricles are fine. But we do see a bit of hyperdensity here, here, here. These are in the subdural spaces. So this patient has a little bit of subdural hemorrhage. And looking by the density, this is quite bright, right? So brighter than the brain. So this one is hyperdense. All right, so this hyperdensity are indicative of more acute hemorrhage. But if you look at peripheral region here, we see a little bit of the collection at the subdural spaces here, but this density is rather similar to the density of the brain parenchyma. And this is what we call isodensity. So this isodensity suggests that the blood is already in the subacute phase. All right. Sometimes the patient will have subdural collection, but the density is similar to the CSF, which is hypodense. So they are either fluid collection only, or they could be a chronic subdural hemorrhage. So this one, whether it is just a subdural effusion, or we call subdural hygroma, or whether it is chronic subdural hemorrhage, it depends on whether we have previous imaging or not. All right, or sometimes you can see features of chronic subdural hemorrhage, which I will be talking about it later in my in the section for non-traumatic head injury. So on your right hand side here, we have another patient. This is in the axial view. And if you all notice, all this CT scan to look for hemorrhage does not need contrast. Okay, do not give contrast for patient if you suspect a intracranial hemorrhage. Why? Because the contrast is bright and the blood we are trying to look is also bright. We do not want the presence of contrast confuse us, missing out any tiny hemorrhage along near the vessels that we thought it was just an enhancement. Padahal is a hemorrhage. So all the CT scan that to look for intracranial hemorrhage should be plain CT brain. So in this patient, you can see actually there is a very fine hyperintensity near the fox, and also a little bit here at the back here, at posterior parietal region is also at the subdural region. And we can see some more hyperdensity at bifrontal region, also in the subdural region. So this patient has acute subdural hemorrhage, bilateral. This patient, the first patient, have all the ages of the subdural hemorrhage. So we usually call this as acute on chronic subdural hemorrhage or acute on subacute subdural hemorrhage. So intracranial hemorrhage, the pattern of intracranial hemorrhage is a must know for medical student level. There's not much thing we can test you, but this intracranial hemorrhage is something very vital that you all have to learn and also acquire the skill to read the CT scan by yourself to detect any intracranial hemorrhage. So the intracranial hemorrhage are being divided into the spaces of the blood which are accumulated in. So whether it is in the epidural space, we call it epidural hemorrhage, or it's a subdural space, we call subdural hemorrhage. Or it can be in the subarachnoid spaces or even intraparenchyma, or another one that I have not been pointed out is intraventricular. So how do we know what type of intracranial hemorrhage this is? So first of all, we look at this epidural hemorrhage. Epidural hemorrhage is something you all need to identify, especially in the trauma setting, because the patient can have a lucid interval of relatively normal GCS and then deteriorate very fast. Okay, because the epidural hemorrhage, sometimes they can accumulate very fast. So initially when they have the trauma, one of the vessels, which is usually the middle meningeal artery, which is being torn because of the skull fracture adjacent to it, and the blood will rush and accumulate in the epidural spaces. And we all know that the brain and our head is a fixed box. Okay, when your skull is already fused, the volume inside the intracranium is a fixed volume. If you have more blood, something else have to go out. So what go out first? Your CSF will go out. So when you have a hemorrhage, you can see all the cerebrospinal fluid spaces, which are the south side, they are all effaced. There is no south side seen. And you can see even the ventricle are being compressed, narrowed, all right? So this is suggestive that this intracranially, the pressure is high. So for epidural hemorrhage, the shape of it is a lenticular shape. Okay, this look like a lens. And usually the hemorrhage doesn't cross the suture. So where are the brain suture? The most important or most prominent is our coronal suture, usually around this level. So you can see that the hematoma, the epidural hematoma, doesn't actually cross anterior to it. And because of the high association with a traumatic brain injury and also skull fracture, every time you found an epidural hemorrhage, look for a skull fracture. It goes both ways. So it means that every time you saw a skull fracture, look for epidural hemorrhage. Sometimes they can be quite small by the time that when you do the CT scan. So interestingly, this epidural hemorrhage will not be limited by will not be limited by fox. Okay, they can actually go behind the fox there. Okay, in contrast to your subdural hemorrhage. There's a little bit of typo there, not limited by fox for epidural hemorrhage. So subdural hemorrhage, if you look at it doesn't really care whether there is a coronal suture down up here or there is a lambdoid suture back there. They just fill up the space. All right, they are not being limited. And if you look at the shape, it's a crescent shape. So this indicates that the blood are accumulated in the subdural spaces rather than the epidural spaces. Okay, when they cross the suture, usually they are a subdural hemorrhage. And they are limited by the fox. Fox is this midline structure here, They go from anterior to posteriorly, dividing our cerebral into right and left cerebral hemisphere. So this is the subdural hemorrhage. Then subarachnoid hemorrhage fills the subarachnoid spaces. So where are the subarachnoid spaces? They are in our basal cistern, right? They are in our sylvian fissure, which is here, and also they are in the sulcus of the cerebral. Sometimes they can be even supratentorial and infratentorial. They all have subarachnoid hemorrhage because the subarachnoid spaces are interconnected to each other, right? So if the subarachnoid hemorrhage is very extensive, they can actually go everywhere. Okay, so this is the subarachnoid hemorrhage, and usually this one we don't really see in pediatric age group patient. It is more common in adult, and if you only see a subarachnoid hemorrhage in adult, they could be due to aneurysm rupture. Then the patient will need a CTA for further investigation. But in pediatric age group, usually the subarachnoid hemorrhage are associated with high impact trauma. But by the time you have these subarachnoid hemorrhages, you usually have other types of intracranial hemorrhages as well, right? So usually in pediatric, the subarachnoid hemorrhage is not a standalone findings that you will find. The next one is the intraparenchymal hemorrhage. This intraparenchymal hemorrhage is in the left basal ganglion. So in the CT scan, your right hand side is the left side of the patient, your left hand side is the right side of the patient. So this part of the hemorrhage is in the left basal ganglia of the patient, and you can see that this hemorrhage has a little bit of hypodensity surrounding it. These are the edema of the surrounding adjacent brain tissue. Okay, and what is inside here is actually the blood. Because of the proximity of this hemorrhage, the blood spilled inside the intraventricular region. So this patient not only have intraparenchymal hemorrhage, it also extends to the intraventricular region. So this is the left lateral ventricle. This is also part of the left lateral ventricle. And you can see how, although the right lateral ventricle, the frontal horn has no blood. Actually, the posterior horn already have some blood inside. And also how the dilated this ventricle is compared to the rest of the hemorrhage, you can see this is quite dilated. So this patient also have concurrent hydrocephalus. Intraparenchymal hemorrhage, they are usually associated with perilesional edema, which is the surrounding hypodensity that I outlined to you just now. All right, and this intraparenchymal hemorrhage, if they are large, they can rupture either into an intraventricular region or they can rupture into the subarachnoid space. So next one is the MRI. MRI is a very excellent imaging modality for pediatric CNS because one thing, they have very good tissue contrast. They have no ionizing radiation. But the problem with MRI is it is not readily available. It's one of the most expensive machines that you will have in the hospital. And also because of the MRI examination itself is quite long. For a pediatric brain sequence, usually it lasts for about 1 hour plus. The patient had to stay inside the MRI room for 1 hour plus. So that's why one day we cannot do many patients, and it has long appointment queue, long examination times, and often in pediatric age group patients, they will need sedation because they cannot cooperate. Although we have other methods to actually make the baby sleep, but most of them actually require sedation. If the sedation fails, the patient even need a general anesthesia just to undergo for MRI. And also the cost of the MRI. Whoever have done an MRI before yourself as a patient, you know how much it is cost, right? Particularly in a private. So the indication of MRI actually can be just everything that you all wanted to know about intracranial pathology, from the hemorrhage, ischemia, infection, inflammation, to the tumor, to look for congenital abnormality, to look for causes of developmental delay or causes of abnormal neurological findings. We can do MRI, okay? And many more. The list is a non-exhaustive list. The only limiting factor is the appointment queue, the long examination time. massage. So this is our MRI machine. It look very similar to the CT scan machine. But in contrast to the CT scan machine, MRI machine is actually a big magnet. So this is what we call a gantry. This donut is a gantry. This gantry inside there house the permanent magnet. Alright, every MRI machine has a permanent magnet. Now this magnet is permanently on. Alright, this magnet is permanently on. Even though at the end of the day, the radiographer have finished their MRI list and they are shutting down the MRI computer and what so, but the MRI magnet will not be shut down. Okay, this is very important because this is a big magnet, so you all cannot bring anything that will be attracted by the magnet into the MRI room. And this is what we call the table or the patient bed. This thing can slide inside and then can send the patient inside and to scan the whatever region that the patient needed to be scanned. And there are a lot of precautions we need to do before we send the patient in the MRI machine. So of course, not everybody can enter the MRI, and we should check for any, because it's a very strong magnetic field and it's always on. So we should check for whether you have accidentally brought in a lot of things or not. Okay, next time when you are a houseman, you know your lab coat will be like the pocket of the Doraemon. Everything will be inside your pocket. So all the metallic things have to be left out. Or best if you can just remove the lab coat. Alright, not even your credit card or your watch or whatever. Because of the magnetic field, the credit card wire inside there can be destroyed as well. And also for patients with pacemaker, we should be cautioned about it. Some pacemaker, they are MR conditioner, some are MR safe, but some of the pacemaker can get faulty when they enter the very strong magnetic field. So all this we have to refer back to what type of pacemaker the patient have, and also the company that sell the pacemaker, see what is the MR status of the pacemaker. So have you ever wondered what actually make the MRI has this very strong magnetic field? What enables it? It's actually because we have a liquid form of helium within the MRI gantry that actually cool down and make the MRI magnetic field always on. So inside the gantry is actually helium. In case of emergency, which involve life and death of someone being trapped inside, sometimes the helium can be released to kill the magnetic field of the MRI. By killing the magnetic field of the MRI machine, you are killing the MRI machine. Right? It's a very, very costly thing. Right? And then this is the cryogenic hazard, that the liquid helium that become a helium gas that will be released out from the MRI machine, that will sometimes it will happen. Okay, and because of the MRI, we use a lot of radio frequency wave, and this radio frequency is actually non-ionizing radiation. It's not a radiation. Okay, it's just a radio frequency wave. We call RF wave, but because of the method of doing the MRI, it is actually a very loud examination. If you all go to YouTube and try to listen to some clip of the MRI RF wave, then you know it is a very loud voice. And this is what can happen. You can see how strong the MRI machine is, that the entire bed of the which is not MRI safe patient bed is being sucked and stick into the MRI gantry. So usually for MRI, we have either contrast or plain MRI brain. So when are we doing contrast, and whether the MRI contrast is safe for patient in pediatric patient? So the MRI contrast is called gadolinium base. For CT scan contrast is a iodine base. All right, so this is a different of it. So MRI contrast is a gadolinium-based contrast, and they are relatively safe for pediatric age group patients. Their allergic adverse effect is actually very low compared to the iodine contrast, and the long-term safety is not yet established. We all believe that gadolinium is excreted via kidney, via the urinary system. So, in a very young child, their glomerular function has not established well yet, has not matured yet, and then hence they have relative physiological renal impairment compared to the adult. So that is when we try to avoid giving gadolinium contrast in very, very young children, such as infant. So less than 1 year old, we try to avoid MRI with contrast. Okay, and also, and this gadolinium has a very peculiar side effect, which is called nephrogenic systemic fibrosis. This is clinically, this patient will develop symptoms rather similar to scleroderma patient, and is a permanent disability, cannot be reversed. Okay, but this nephrogenic systemic fibrosis (NSF) adverse effect is actually very rare in children as well. But they found that the precipitated risk factor to get this NSF is very, very poor kidney function. So in patient with renal impairment, history of renal impairment, we need to check for the renal function before the MRI examination, okay? Because sometimes, although we plan for a plain MRI study, if we found any pathology, we will need to deliver contrast for us to have more information from the MRI. Okay, so before the sending the patient for appointment or to attend the MRI appointment, just make sure to talk to your radiological team, see whether the patient will need a contrast or no contrast, and whether you all need to check the kidney function or not. Okay? And this gadolinium is also recently found that it will deposit in the brain, actually in a lot of organs, such as skin and bones. All right, so if the pediatric patient has repetitive MRI scan or MRI study with contrast, slowly we found out that even the plain study, there are certain organs in the brain or certain parts in the brain that will be bright even without giving contrast. Ah. However, the long-term effect of this gadolinium deposition has not been established, so we do not know what will happen to the patient. So this is the basics of MRI. It is similar to like the adult for patient who has complete their myelination. Okay, we know when the patient is a newborn baby, the brain have not completely myelinate yet. The myelination of the brain, the process will complete usually by the first year of life. The T1 weighted image, the myelination will look rather complete, and at the age of 2 years old, usually the T2 weighted image will also show complete myelination. Right, so this on the left hand side here is the T1 weighted image, and on the right here is the T2 weighted image. I will not go too detailed in it because for medical student level, you all doesn't really need to know how to interpret the MRI. Okay, but just have a rough idea that MRI is not like CT scan. CT scan, we scan one time and that's it, patient go out. All right, but MRI, we need a lot of different sequence because the different sequence give us different information. So for example, the T1 weighted image is very similar to your CT brain. Okay, your gray matter is grayish and your white matter here is whitish. All right, this is what the T1 weighted image look like. And if you look at the CSF spaces, be it in the ventricle or in the south side, they are also dark. They have no signal. This look like a CT scan, right? But it has very much detail compared to the CT scan. Okay, CT scan is more grainy, and this one is give you a very good tissue contrast and a very smooth image. And on your right hand side here, which is something not very familiar to you all, is the T2 weighted image. The T2 weighted image is Usually the T2 weighted image is being used to detect pathology. T1 image is to look at the anatomy, and then the T2 image is usually to detect any pathology. A lot of pathology or a lot of abnormality will be bright on T2. Okay, so we are trying to look for any areas of the brains that are bright on the T2 weighted image. So what are also bright on T2? You can see the fluid is also bright. Okay, so all the T2, all the fluids will be bright. And in contrast to T1, the gray matter is brighter and the white matter is darker on T2. And now this one is the post-contrast image, T1 post-contrast, after the gadolinium contrast. Okay, you can see that it is quite similar to the plain T1 here, T1 weighted image, but the post-contrast T1 weighted image has vessel enhancement. Okay, if there is pathology, for example, area of infection or a tumor, it will further light up with the contrast. Or some of the tumor, they might not enhance after the contrast. So the contrast gives us further information on the lesion that we are looking for or examining. Okay, but the contrast will light up all the vessels and also the dural venous sinuses. So now come to the last modality that I want to talk, which is the skull radiograph. Skull radiograph, this skull examination, skull x-ray is something that I very discourage people to perform on pediatric. Why is that so? All right, in a traumatic setting, remember just now I show you uh, the recommendation by the PCAN, right? It's actually not recommended in the traumatic setting. A lot of studies and also research has found that the sensitivity of the skull radiograph 1 is very low. When the sensitivity is very low, it is not a good screening tool. Okay, and also it has a very poor indicator for intracranial injury, meaning that if your skull radiograph is negative, you might not, it doesn't really correlate whether the patient have, how severe is the intracranial injury. Okay, so, and that's why even the normal skull x-ray, you can miss a very severe intracranial injury. So the clinician should assess the patient clinically and see whether the patient need a CT brain or no in the setting of trauma. Okay, so if the imaging is indicated, go for CT scan. If the imaging is not indicated, do not even bother to do a skull radiograph. Why do you need to irradiate the patient furthermore when your skull x-ray has very low sensitivity compared to your CT scan, right? And also a very poor indicator. So the skull radiograph, when should we do the skull radiograph? This skull radiograph is usually part of the skeletal survey. The skeletal survey is either for non-accidental injury or for skeletal dysplasia or metabolic diseases. Okay, in the setting of trauma, try to avoid skull radiograph. All right. If it's significant traumatic history, CT scan should be performed. Okay, if it's not indicated, then nothing is indicated. Don't be because the CT scan is not indicated, I buat lah skull x-ray je. For what, right? It is low sensitivity. So now I revise you all again about the guidelines, the decision guide that I have mentioned just now. You can see that in this guideline, they didn't even write any skull x-ray, nothing. It is on the CT scan. So if it's indicated, do CT. If it's not indicated, observe, give reassurance to the patient, and if the patient is stable, then discharge. All right. And this is for the 2 years older, and you can see that there is no role of skull radiograph in the decision guidelines. So next time when you all become a houseman, remember today's teaching. Don't do skull x-ray. Okay, if it's indicated, the patient will need a CT scan. If it's not indicated, nothing should be done. Observe the patient closely. If the patient deteriorate or develop new symptoms which are alarming, ask for a CT scan. If not, reassure the parents and can discharge the patient. So now we talk about abusive head trauma. This abusive head trauma is what we call a non-accidental injury of the head. This abusive head trauma has very high mortality rate, and patients who suffer from head trauma from abuse, 25%, 1 in 4 will pass away because of the head trauma, abusive head trauma. And those who survive, 80% will suffer for permanent disability and brain damage. See, this is something very sad. Child, they cannot defend themselves and cannot protect themselves. All right, so what are the mechanism of abusive head trauma? They are usually by shaken baby syndrome. So meaning that the abuser hold the baby up and then do the shaking action, and that is when the injury happen. Okay, it's not a direct blow of force or what to the brain, but it's because of the sheer force in the shaking action. So even when you are playing with baby, do not shake them. There will be a time where the baby have bigger skull, smaller brain, because the brain need time to catch up to fill the skull. So when the space is a lot, the bridging vein all can torn. All right, even the buoyant, in the Asian family, we like to put the buoyant there, right? To put the baby on that. If we shake too vigorously, also it can cause intracranial hemorrhage. So do not shake the baby. And what happens when the baby is being shaken? The veins in the subarachnoid spaces, in the CSS spaces, can torn. Those veins are called bridging vein, and they are usually the cause of subdural hemorrhage. And also the brain, because the brain matter itself is hitting in the inner skull surface when you do the anterior and posterior motion in the shaking. It can crash onto the skull and cause contusion. Apart from that, the neck, the cranial cervical junction of the baby is very vulnerable. The cervical spine or the cranial cervical junction here is an area where the breathing control, autonomic breathing control, everything, breathing center is a respiratory center. So if this part is being injured, the patient can die. So the important imaging finding is subdural collection. So why do I say it's subdural collection? This one was quite chanted before I put out. I don't know why all run away. So the subdural collection can either be the torn of the bridging vein. Another thing that can torn is the meningia. Meninges can torn. Meninges is the layer that protects the brain. It also can torn. So when it torns, it will have CSF that accumulate. Okay, this meninges, when it's torn, it causes the cerebral spinal fluid accumulation. And if the bridging vein is torn, this bridging vein carry blood, right? So it could cause a hematoma. If it's a mixture of bridging vein and also the meningia which are torn, so they can have a mixture of blood and also CSF fluid. Then you can have something like a straw color or like a pinkish straw color fluid collecting in the subdural region. So that is why the title of imaging findings is a subdural collection, not the hematoma per se. Hematoma is just one of the subdural collection. Okay, so it can be the blood that is collecting in the subdural spaces because subdural hemorrhage, or it can be a CSS fluid because of the meningeal tear. We call it subdural hygroma, or it can be the mixture of the blood and also the CSF. We call subdural hematohygroma. In the subdural hemorrhage or hematoma here, we can divide into acute and chronic because they look different in the imaging. So first of all, we talk about the subdural hemorrhage. In an acute subdural hemorrhage, which I have already shown in previous slide, they are hyperdense. Alright, this cartoon is the CT scan or T1 meter image. Alright, the subdural spaces will be bright. Okay, the whitish thing is the acute blood. You can see this is the CT scan of the patient. The patient has a left frontal subdural hemorrhage, acute one. Alright, so what happened in a chronic subdural hemorrhage? It will form septum. We call it your septum in the subdural spaces. Alright, and we have areas of previously it was the dense blood. Then when the blood has breakdown, it now become more fluidy, like more like CSF, which can be hypodense. Right, so this is a T2 weighted image. Just now when I said T2 weighted image, all the fluid, all the CSF fluid, you see this one are all bright. Okay, all these are fluid. Okay, they are not really that much of blood inside, but they have some layers behind. You can see at the arrow head here and there, they have locules of different density layering. Why there is locule? Because there is myoseptum that is being formed, this septum here. And we have this subdural hematohygroma, which has the mixed density. You can see it's grayish color. This one is in the T2 weighted image. Even in the CT scan also it look gray. And if for the subdural hygroma, it follows the density of the CSF fluid. And you can see this one has a fluid accumulation in bilateral frontal region at the subdural space, the subdural hygroma, because of the accumulation of fluid. So not necessarily they will have blood. Sometimes it's only the meninges which is there. Then they can have all this fluid collection. So bear in mind, it will not necessarily to be a blood. And the next important finding in abusive trauma is a hypoxic ischemic injury. It can be focal or diffuse. You can see in this CT brain, the patient has no gray matter differentiation anymore. It is all hypointense. And you can see that the patient also have acute subdural hemorrhage pointed out by the arrow. This is at along the falx cerebri and also some at the region adjacent to it. And this is the metopic suture, coronal suture here, and they are all widened. Okay, there is also sutural diastasis. Other important imaging finding is acute head traumatic injury is retinal hemorrhage. Venous thrombosis is also quite common, and also skull fracture we have to look for. And this is a very sad long-term sequelae of abusive head trauma, and that's why 80% of the patient will have permanent neurological deficit. And you can see in the acute stage, it is just some changes in the cortex which are swollen up over the left hemisphere and also the right frontal region, sparing probably around the right frontal temporal region. So in 2 months later, just 2 months later, this T2 weighted image show you all the brain has gone. Okay, all these have no more viable brain. We call it cystic encephalomalacia changes. Right, meaning the brain has died off. The only remaining part is here. And in pediatric brain tumor, this is a very hi-fi topic. For medical students, we are not expecting much. So, but just for introduction, it is the most common solid childhood cancer. So it's actually the second most common childhood cancer after leukemia. Okay, after hematological malignancy. But hematological malignancy is not a solid cancer. So this is a solid cancer. And it classified usually by the location of the tumor, supratentorial, infratentorial, and if the patient is less than 60 days old, we call it congenital brain tumor, and they have the higher frequency or higher causes of this congenital brain tumor is a germ cell tumor. And if the age is more than or less than 1 year old, it's a tumors of infancy. As the patient age bigger, the brain tumor is more likely to be from the brain cell itself. So this is by the age. You can see that if it's 3 years or younger, you have more supratentorial tumor than the infratentorial tumor. And if you are more than 10 years old, you are roughly about the similar supratentorial, infratentorial. So what do I mean by supratentorial? Remember, we have something called tentorium cerebelli that divides the cerebral hemisphere with our posterior cranial fossa structure, which is the cerebellum and also vermis. So that line is what we call dividing a supratentorial above the tentorium, or inferior to the tentorium, we call infratentorial. So the most common childhood brain tumor is actually pilocystic astrocytoma, followed by medulloblastoma and other type of brain tumor. And this is the one of the example. This is a 6-year-old patient with has nausea and vomiting for 2 months, and you can see that at the right cerebral hemisphere here there is a lesion, a solid brain tumor, and also it has areas of cysts, and you can see how it is involving the optic chiasm here. This one you all no need to know. Just sit back and enjoy this. And then you can see after the contrast, it has a very enhancing. This is a case of pilocystic astrocytoma. And for the posterior cranial fossa tumor, this is the most feared tumor, which is the medulloblastoma. And this patient is a 9-year-old boy. You can see in the fourth ventricle here, there is a solid tumor sitting inside, and it already seeding, having some tumor spread or seeding in the rest of the cerebellum here. And I do have the whole spine images in my computer. The patient actually already have spine metastasis. And this is the 8 days old only. This is one of the example of congenital brain tumor, and you can see this is city brain, and you can see the calcification, and you can see some area of more denser region, and also area of very hypodense. But this one is not fluid. These are fat, so it has a calcification and fat. This is a teratoma. And the other girl is a 2-year-old girl with a diffuse midline glioma, and this is the pons of the patient. You can see how swollen the pons is, and this is the basilar artery which is being engulfed. So CNS infection, we are dividing into congenital infection and also postnatal infection. So congenital infection, usually we will try to screen with ultrasound first, and we'll do the ultrasound first, and then we proceed with MRI, with or without CT brain. Usually we don't need a CT brain. But postnatal infection, not necessarily we need to do imaging for postnatal infection. If you suspect a meningitis, the most important thing to do is actually the lumbar puncture to know what is the organism, and also whether it's more bacteria or more something else. All right. For the imaging investigation in postnatal infection, it's actually just to look for complication. Okay, so not all patients that you suspect meningitis need a CT or MRI. No, not all. Okay, it is just to look for the complication of this thing. The imaging modality in a very young neonate or young infant, we can do ultrasound, and then sometimes we can do CT brain with contrast and also MRI. So this is the ultrasound images. This is the linear probe, and you can see that there is collection in the subdural spaces with multiple septa within. This is the subdural empyema. Okay, it is a complication of meningitis. In the CT scan, it looked like there is locule of fluid with rim enhancement in the subdural spaces. And these are the patient with TB infection of the CNS. You can see multiple rim enhancing lesions are scattered in the basal system. And this is the brain abscess. Sometimes they do not form abscess, but they are just inflamed. They are causing inflammation of the cerebral, so cerebritis. This is at the temporal region is particularly famous for herpes simplex encephalitis. So now come to which imaging study to order. This is usually our exam question to you all. Okay, what is the next modality to be done, or what should you do? What type of the imaging study you should pick? Okay, for traumatic brain head injury, do CT brain, no skull X-ray, no ultrasound. Abusive head trauma, you can do a plain CT, or you can start with ultrasound brain if the patient is very young, and then might need to proceed with CT, either a CT brain or a MRI. And if you suspect any tumor, do MRI. Okay, if it's a complicated CNS infection, less than 9 months old, actually it's 6 months, but sometimes we give a leeway because because the MRI is very hard to wait. And the other thing is sometimes we do not want to subject the patient straight away for CT brain. Okay, so sometimes less than 9 months, less than 6 months old, we can still do ultrasound brain. So take home message is to avoid ionizing radiation, which is the skull radiograph. Okay, and also CT brain as much as we can in pediatric age group patient. Assess your patient properly. Don't just anything when you want imaging, no such thing. Infection, do lumbar puncture first. Our imaging is not going to diagnose a meningitis for you. Okay, and skull radiograph no longer recommended in traumatic setting, and not all trauma need a CT scan. Suspected NNI cases are particularly in the cases of subdural collection. Every time we see a subdural collection in a patient, we have to raise the possibility of NAI. Thank you. In terms of, I think I just passed 1 minute. So if you all have any question, can type in the chat box. I will try to reply. I will stay in the Zoom for another 15 minutes. Is that all right?
Okay, doctor. Thank you.
Okay, doctor.
Thank you.
Doctor, can I ask a question?
Ah,
Because we cannot access, you can follow. Is it okay if doctor pass us the slides or pass me the slides through email or WhatsApp if possible?
oh. Bukan you all sudah record ke?
Yeah, oh yeah, the lecture is being recorded. It's
Ah,
okay. Can, doctor.
ah.
Hello, good afternoon, Chai. How are you?
Okay, hi Prof. Sorry, ambil your masa sikit.
Oh ya,
Hehe.
sikit je. Okey je. Okay. You guys want to catch your breath and then pergi ke toilet sekejap ke, and then I think we'll review another 3 minutes. Cepat dah.
Boleh, Prof.